I worked hard on that write-up and I thought that some of you would have read it. Dr. P K Mangla sir said, what a wonderful write-up you have written. Being a pulmonologist, I can understand the nitty-gritty of that write-up. And I got good comments from Dr. JPS Tulsi sir and some of our friends. Thank you very much. Today's CME is about asthma, a very common clinical condition. And it spans the entire life journey of a person from early childhood to early adolescence, young age, and even late onset asthma. Who better than Dr. P K Mangla sir to introduce the topic? Dr. P K Mangla sir is an icon in pulmonology. He has been to every South Delhi nursing home, hospital. At present, he is heading the Department of Pulmonology in Mulchand Hospital, Critical Care Medicine and Sleep Medicine. I request sir to welcome our first speaker for today evening, Dr. Vivek Nangia sir, and to introduce the topic. Ladies and gentlemen, for the 843rd time, thank you.
Good evening, friends. I welcome you all to this 843 CME of Physician Forum of India. The topic is again asthma. You see, when I was doing my PG, the asthma was only Aspirin, Daripyrin, Theoaspirin, Tetrol, SA, and these were the drugs. And as and when the patient came to the clinic and he said that he is not better, the doses of these drugs were increased. And patients were still worse, trembling, irritable, but not that. Even with this treatment, they used to get better. Quacks were treating asthma better than allopathic doctors because they were giving steroids in Korea and we were giving bronchodilator. Then came the era of inhalers, especially steroids, and this came as a boon because those side effects which were with these oral beta-2 agonists were reduced to quite an extent. But even every individual is different, every asthmatic is different. You see, somebody will get better with SOS, aspirin, or beta-2 agonist and steroid combination taken twice a day at SOS. Somebody with oral steroid, all the treatments, whatever are available, they will not be better and they will be requiring frequent courses of steroids. Now has come the era of targeted therapy, phenotyping asthma, endotyping asthma, and treatments are based on that. Today's topic is the drugs, anti-eosinophilic targeting drugs, and Dr. Vivek Nangia, who is heading the Department of Pulmonary Critical Care and Sleep Medicine at Max Healthcare. I invite Dr. Vivek Nangia.
A very good evening to all of you, and it's indeed, again I would like to reiterate that it's indeed a pleasure and honor for me to be here this evening again. This is probably the third time that I'm coming here, and always with the same amount of excitement and same amount of enthusiasm of coming and meeting you all. I think very soon we'll also start attending your meetings regularly. They're so informative. Now that Dr. Chauhan has been sending me also messages every week about the upcoming meetings, and I really find them very interesting and very educative. And in fact, Dr. Chauhan's message this morning says it all about what I'm going to talk. I was really wondering that what to talk now. You know, when Dr. Chauhan has already described asthma, the phenotypes and the endotypes as well. He's reached the endotype stage also. I think one more message and he would have completed my talk in that one paragraph itself. But anyway, now that he has invited me to speak, so I will. Asthma, as we all know, is a heterogeneous disease which is usually characterized by chronic airway inflammation. It's usually associated with airway hyperresponsiveness and airway inflammation. So there is airway hyperresponsiveness and an inflammation going on in the airways of these patients who are suffering with asthma. There are of course recognizable clusters of demographic, clinical, pathophysiological characteristics which are often called the asthma phenotypes.
But then you actually see that they do not correlate so strongly as far as the specific pathological processes or treatment modalities are concerned. Therefore, the need for endotypes. Endotypes have actually transformed the complete treatment of asthma now. When you get a patient of asthma, what do? The first thing is reach a diagnosis of asthma. You get a chest X-ray done, you get a CBC done, you get a PFT done. PFT in all likelihood would give you a diagnosis of asthma. If not, then you have to look at the variability. A patient with asthma could have symptoms in the morning and could be absolutely asymptomatic by the evening. So you examine a patient's chest in the morning, it's full of wheeze. By the evening you see the wheeze might have disappeared because it's a variable kind of a disease, a heterogeneous variable kind of a disease. I remember we used to have a patient who would go into acute respiratory distress, land up on the ventilator, he would be intubated somewhere in Noida, shifted to us as Port and Basant Kunj, and by the time he would reach us, there would be no wheeze at all. Within 24 hours, we would be able to extubate him off the ventilator also. So that was the variability, the brittle asthma that he had. He would be wheezy one day, get intubated, and by next day there would be no wheeze, get extubated. So in such kind of patients, we usually advise them to keep a peak flow meter with them and keep monitoring their expiratory flow rates to see the variability and conclude that whether this patient actually has asthma or not. I remember very well for that patient, he underwent a battery of investigation to rule out cardiac illness, pulmonary embolism, but never did we find anything on him except once when I finally detected wheeze, and this was probably his second or third episode of getting intubated, ventilated in Noida and being shifted to us because that was his place of work and he would come to me for his treatment. So, and I would always tell him, I'm not able to find a cause for you, why do you go so breathless and why do you land up on the ventilator? Finally, one day when he got PFT done, it showed that there was apparent wheezing and an obstruction in his airways. So when you get a patient of asthma, Dr. Amina will discuss with you what are the steps, how you increase the therapy for them. And once standard treatment would be use of a long-acting beta agonist along with an inhaled corticosteroid, probably add on a long-acting muscarinic agent also to it and see if the patient is doing well or not. So is your patient under control once the patient has been started on treatment? Our first line treatment would be to start somebody on a Symbicort along with a tiotropium and then see whether the patient is doing well on the treatment or not. So what is the criteria to see if the patient's asthma is under control or not? You basically have to take these 4 points into consideration: whether the patient has any daytime symptoms or not in the last 4 weeks, any waking due to asthma, whether the patient has used his short-acting bronchodilator, that is like your Asthaline or levosalbutamol or any of those kind of inhalers which are not used anymore now. Let me say very categorically, levosalbutamol or Asthaline that we use as an SOS inhaler or regular therapy is no longer a treatment modality in the current management guidelines for asthma. Whenever you're using it, it must be with an inhaled corticosteroid. Typically what Symbicort has. A formoterol along with a budesonide as a combination should be used as your first line treatment, also as your reliever treatment. So the time and era where we used to use Duolin or we used to use Asthaline or Duolin inhalers or Aerocords is gone completely. We only rely on long-acting bronchodilators like a formoterol with an inhaled corticosteroid like a budesonide as your mainstay treatment as well as your reliever treatment. Having said that, you look at these 4 parameters, whether the patient's nighttime activities are disturbed, whether the patient's daytime activities are disturbed or not, and then classify the patient whether this is controlled asthma or uncontrolled asthma. In addition to this, you also have to keep in mind the various risk factors that a patient may be having, which predispose this patient to an increased risk of exacerbations. Like somebody who's requiring SABAs, that is the short-acting bronchodilators too often, has other medical conditions like obesity, chronic rhinosinusitis, gastroesophageal reflux, food allergies, pregnancies. You have to keep all these in mind. Gastroesophageal reflux and chronic rhinosinusitis are two entities which are very commonly seen in asthma patients. And in my experience of last 26, 27 years, you treat these and then asthma comes under control. Sometimes patients don't even give you the classical history of gastroesophageal reflux or a sinusitis or a postnasal drip. But if you elicit it properly, they would say, yeah, once in a while I do get this tickling sensation. Once in a while, whenever I have an asthmatic episode, it starts with a cold. So you treat these entities and the asthma also comes under control subsequently. Along with that, you look at the major psychological issues, even an emotional distress, like too much of happiness or too much of sadness, excitement, speaking loudly, shouting, would all trigger on an asthma episode. And then of course, what we call as a type 2 inflammation, which I just come to. So if somebody has all these risk factors, be prepared that he is a very high risk candidate for an exacerbation soon. One exacerbation is a risk factor for another exacerbation coming up soon. And sooner than the first exacerbation. So this is what brings us to the definition of what is uncontrolled asthma. Uncontrolled asthma would be somebody who has daytime disturbances in his, daytime symptoms, who has nighttime disturbances, who is requiring more often than what is required a short-acting beta agonist or reliever therapy. Those would be the symptoms that you would consider as uncontrolled asthma despite being on regular medication with a LAMA and probably LAMA and ICS and probably LAMA also associated with it, or somebody who is getting frequent exacerbations. So how do you approach this patient who has uncontrolled asthma? You basically try and figure out if the patient's technique is proper, the comorbidities like rhinosinusitis, obesity, sleep apnea. Once you've tackled all this and yet the patient is not improving, then you label them as severe asthma. So there is an entity called uncontrolled asthma where the symptoms are prolonged. Then there is difficult to treat asthma where you look at all these aspects, that whether your even basic diagnosis of asthma is correct or not. And if you having done all this and patient is continuing to have symptoms, then you label the patient as severe asthma. Now when you look at the pathophysiology of all these patients, you will find it can basically be allergic in nature, which is IgE mediated. It could be eosinophilic in nature, which is non-allergic type, which we call as a Th2 kind of an inflammation, type 2 inflammation, which is becoming more and more common these days. And then of course, there could be a neutrophilic infiltration that is causing their asthma. Eosinophilic maturation, as we all know, starts in the bone marrow. Eosinophils then circulate into the peripheral blood and then reach the inflamed tissues of the lung. So is eosinophil the right marker for severe asthma? Well, we all know that it's terminally differentiated granulocyte. It's named after the eosin dye which stains positive with these granules. It exists amongst the virtually all vertebrates, has numerous cell surfaces. Putative physiology roles in health and disease spanning innate immune functions, anti-helminth activity, tissue inflammation, and tissue homeostasis. So it basically helps in anti-helminth defenses, antiviral responses, antibacterial, antifungal, adiposity control, mucosal surface maintenance, and tissue development, remodeling, and repair. These are all the roles of eosinophil. Now when you test the eosinophil levels, it is not the percentage that is important. It is the absolute eosinophil count that is important. You know, sometimes when you get the lab reports, it only says 2%, 3%, 5%, but then you have to look at the total leukocyte count. Somebody with a total leukocyte count of say 20,000, if has 5% eosinophils, that means it will be 400 eosinophils which are significant. Similarly, if somebody has a THC count of 10,000 and the eosinophils are say 20%, that means 2,000 are the eosinophils. So it's the absolute eosinophil value that is important and not the percentage. So either most of these newer generation labs are giving you the ADC also along with it, you need to focus there, or if it is not given, then you just derive it from the total leukocyte count that has been given to you. So when it is between 0 to 500, you will get entities like allergic rhinitis, urticaria. You have to think of these kind of diseases. If it moves from 500 to 1500, then you have to think of asthma, atopic dermatitis, bullous pemphigoid. If it is more than 1500, then you label the patient as hypereosinophilia and start thinking of either a vasculitis, some kind of a tumor, eosinophilic lymphomas are known to, leukemias are known to cause, lymphomas are known to cause, or you label them as a hypereosinophilic syndrome. EGPA, that is eosinophilic granulomatosis with polyangiitis, is what Wegener's disease used to be earlier. It's the same, it's a different name now, newer name for it. So you explore that possibility in these patients. So you look at absolute eosinophil count these days. My standard prescription for any first timer coming to me in the OPD with a history of bronchial, history suggestive of bronchial asthma would be a CBC with AEC, with an IgE level, with a chest X-ray and a PFT. And the patient will get a peak flow meter with him next time so that we can monitor the peak flow rates at home and teach them the home asthma plan, that how to manage it at home on their own. When to take a reliever, when to continue with the controller therapy. So, eosinophil impacts the asthma very severely. It is mediated through the various interleukins, especially interleukin 5 and some other eosinophil activating cytokines, which then result in inflammation and certain non-immune effects. If you see that what is the likelihood of a patient with severe asthma being eosinophilic, it's not almost equal to 84% of the patient with severe asthma would have eosinophilia associated with them. The eosinophilic phenotype can also be identified clinically if there is presence of comorbid nasal polyposis, which is quite often. So an X-ray PNS or a CT sinuses can also form a part of your initial workup for these patients. A positive response to steroids, if the patient is improved with steroids, would mean that he could be having an eosinophilic asthma. An adult onset asthma, as contrast to a childhood asthma. Childhood asthma is mainly IgE mediated, whereas an adult onset asthma is mainly eosinophilic mediated. And then again, if the patient is going into frequent severe exacerbations, it could give you an indication that this patient could be having an eosinophilic asthma. This is a study from our own country where 50% of the patients with severe asthma were eosinophilic. This is a profile that has been published where 20% of non-atopic, 20% had a non-atopic eosinophilic asthma, while 29% had eosinophilic asthma with atopy overlap asthma. That means they had IgE also elevated. So there about 50% of the patients would be falling into this high eosinophil category. And please note that if the blood eosinophil levels are high, then the chances of proper control are poorer and the chances of exacerbation are much higher. So as the number of eosinophil counts go higher and higher, the chances of severe exacerbations go higher and higher, acute respiratory events go higher and higher, and asthma control becomes poorer and poorer. So there is a direct link between the eosinophil levels and the severity of asthma, and an indirect link with the control of asthma. So how do we manage these patients? First of all, we have to diagnose the patient to be a difficult to treat asthma, as I just said. So you confirm the diagnosis of asthma, look for factors contributing to the symptoms, like if you've looked at the allergic factors or not, remove the triggers that could be causing this, and treat the comorbidities properly. Look at any underlying morbidity which has not been treated or which has been ignored so far, the modifiable risk factors and the triggers. Optimize their medical management. So initially you start with an ICS and a LAVA combination, typically like a Symbicort, followed by addition of a long-acting muscarinic agent, followed by montelukast, followed by azithromycin as an alternate day therapy. Hold on there. If the patient is still not settled, rework up the patient all over again and see where the patient falls into. Review the response to your treatment after 3 months, and if asthma is still uncontrolled, then you label this patient as severe asthma. So 3 months is the time frame that you look at, and you go through the entire rigmarole of all these investigations all over again, including the eosinophil levels, and then see where you stand. So if the blood eosinophil levels are high, more than 150, that means this patient is falling into the eosinophilic category. Along with it, if the FeNO, that is the forced expired nitric oxide levels, if they are also high, more than 20, you can definitely consider this patient to be having a Th2 inflammation. Frequent exacerbations in the past, and then this FeNO levels and the AEC levels are not to be measured only once. You check them about 3 times at least on different occasions and see the levels, how high they are. Especially if the patient has been on oral corticosteroids, then there is a very high likelihood that you may get a low eosinophil levels falsely, because the oral corticosteroids will suppress the eosinophil formation. And then, if the patient is still continuing to be unwell, then you have the option where the eosinophil levels are high, then this patient would be considered for biologic therapy. If the eosinophil levels are not high, then that means this is a non-Th2 kind of an inflammation. You again need to relook at your clinical profile of the patient, the various parameters that have been tested, including their comorbidities. You start treating them, and for these patients, probably steroids would be an answer, but again that would be kept as a last reserve, and you do not start them otherwise. And of course, you have to, these patients, LAMA, and then finally, after the ICS are not improving, you have to consider a biologic for these patients. GINA recommends consideration of maintenance oral corticosteroids only as a last resort. So after having worked up, now which biologic to be used for this patient? So the first thing you get done is an IgE level. If the IgE level is high, then you have to consider using omalizumab as your drug of choice. If your absolute eosinophil count is normal, but the IgE level is high, then omalizumab is a drug of choice. Especially if it is associated with dermatitis, atopy, is childhood onset asthma. These patients do well with omalizumab. If the eosinophil levels are high and patient is continuing to be in a state of severe asthma, then benzalazumab, mepolizumab or resilizumab, 3 drugs are the anti-eosinophil drugs that can be used. Out of this, resilizumab is not available in India. Only mepolizumab and benzalazumab are the 2 drugs that are available to us. And benzalazumab has been shown to be more effective, and I'll just come to that. So if the eosinophil levels are high, you could look at the blood. If the blood eosinophil levels are high, and there are frequent exacerbations in the past. If patient is, if the eosinophil levels are not high, and yet the eosinophil levels are high and patient has frequent exacerbation, another drug that can be used is dupilumab. Unfortunately, this is also not available to us yet. And if none of this is there, patient is steroid dependent, then there is a new drug that has come, that is the anti-TSLP, that is called the tezolizumab drug, which again is not available to us. So we are left with only 3 drugs: omalizumab, mepolizumab, and mepolizumab. Now, when you start this therapy, if the patient is doing well, you monitor them for at least you should give them for the first 4 months before you really check the response of the patient. You do not stop it before the first 4 months. If the patient is doing well, then you continue with them for at least 1 year. If the patient is not doing well, then you rethink your strategy, but at least give them a 4 months opportunity to try out these drugs. And somebody who is responding, you would continue it for 1 year. Now there is an inverse association between the use of OCS and the blood eosinophil counts. The oral corticosteroid usage would go on, once you increase the dosage, the eosinophil levels will start coming down. Once you reduce the dosage, the eosinophil levels keeps going up. Now which biologic to use? Now coming on to the specific ones, when you're using an anti-IgE, young onset, children, childhood asthma, IgE is elevated, especially to an aero allergen like a house dust mite or pollen, then you would consider using omalizumab. But if it is an eosinophilic predominant asthma in elderly, adults with chronic rhinosinusitis, polyp formations, then you would not consider IgE level anywhere. You would start these patients on one of the anti-IL-5 drugs. Benzalazumab would be the drug of choice here. Omalizumab has huge limitations. It can only be given to somebody up till 750 of IgE and not beyond that, because it has to be according to the IgE and the body weight. There is a chart that is given, so you decide based on that. Mepolizumab can be given to 18 years and above for eosinophilic phenotype. Benralizumab also to the similar phenotype. GINA guideline mentioned that it could be given to eosinophil more than equal to 150, and the dosage is very simple. You give them 30 milligrams subcutaneously once a month for the first 3 months, and then once in 2 months for the subsequent. So when you look at whether both the biologics are same, benralizumab and mepolizumab, well, let me tell you that there are no head-to-head trials. But if you extrapolate the data from the trials that have already been conducted, I would say benralizumab stands a better chance as compared to mepolizumab. It binds directly to the IL-5 receptors on the eosinophils. It recruits the natural killer cells and causes apoptosis of the eosinophils, thus killing the eosinophils completely and blocking the inflammatory cascade. When you look at the acute exacerbations with the use of benralizumab and mepolizumab, again, benralizumab scores better. There were patients with zero exacerbations to the extent of 63%, 77% and 75% in different studies. And when you look at in this particular study, Zaloc 1 RWE, there was a relative risk reduction in the acute exacerbation by 84% in patients where the eosinophil levels were elevated. If it was more than 300, then 85%. If it was between 150 and 300, then 81%. Overall, the hospitalization reduction in mepolizumab group was 72%, whereas the benralizumab group was 93% reduction in hospitalization in these studies. There was an improvement in FEV1. With benralizumab, there was a consistent improvement in FEV1 which was maintained for a year in some of these patients, whereas in mepolizumab, there was an initial improvement followed by a decline in the FEV1 values. As far as reduction in the use of oral corticosteroids is concerned, in the Gonda study, with benralizumab, it was reduced by 75%, whereas in mepolizumab, it has ranged from 14% to 50% and not more than that. Whereas if you see the benralizumab, then the reduction has been quite significant in most of these studies. These are the studies showing a constant reduction and significant and sustained improvement in asthma control as well as the quality of life with the use of benralizumab versus mepolizumab. So to sum it all up, the mechanism of action, as I said, is slightly different between the two drugs. The acute exacerbation rates were lesser with there was a greater reduction with the use of benralizumab as compared to mepoli. The hospitalizations were significantly reduced in the benralizumab group. There was a significant improvement with the use of FEV1, and there was a significant reduction in the requirement of oral corticosteroids. The quality of life obviously was better in this group. Then there is also something called a super responder, where the patients have significant improvement with the use of these biologics, and there are these two real-world studies that have come out with their own data with the use of these biologic agents, and they've shown that when you compare benralizumab versus mepolizumab, there were better super responders and responders, larger fraction of patients with the use of benralizumab as compared to mepolizumab. So it was important to identify these super responders to benralizumab, and again, higher eosinophil levels, presence of nasal polyposis, adult onset asthma, they were all associated, and frequent exacerbations were associated with a greater response with the use of benralizumab. Some people feel that may be concerned that you're completely depleting the patients of their eosinophils, but if you compare the various studies, they have not shown any significant difference as far as helminthic infections was concerned, pneumonia was concerned, upper respiratory tract infections were concerned, or cancers were concerned. So they're absolutely safe to use with no significant side effects that we've encountered. So to sum it all up, eosinophil is an important marker for identifying a severe asthma patient. GINA guidelines mention that an eosinophil level of more than 50 with symptoms suggestive of severe asthma should be considered for a biologic agent. Benralizumab seems to be a drug of choice in these situations with severe eosinophilic asthma with eosinophil levels of more than 150, and when you compare the two, Vendrali versus Benvolio, then of course, as I just described, Vendrali stands tall, stands up. With those words, I'd like to thank you all for inviting me here.
Namaskar, good evening everyone, and I would like to extend my gratitude for giving me the opportunity to speak here. So I'm going to be quickly sharing 3 cases which have been very gratifying for us and also for the patients who we've treated. So Dr. Nangia just described the role of biologics in the treatment of asthma. So basically we go on to evaluate a patient for biologics if the person is on LABA/LAMA high dose ICS along with NTRAs also, and even then is having exacerbations or is steroid dependent. So basically in GINA step 5 comes the role of evaluation of the patient for biologic therapy. So my first case is of a 60-year-old male who is a known case of bronchial asthma, ABPA. Recent PFT showed obstruction with significant reversibility. He presented to our emergency in an exacerbation with a history of cough, phlegm, fever for about 4 to 5 days. He was desaturating to 88% with extensive bilateral wheezing and scattered creps. We started him on antibiotics, bronchodilators and IV steroids. If we went back to his history, he was on oral corticosteroids on a maintenance dose of around 10 mg of prednisolone since last 1 year, and he reported that his symptoms recurred within 15 to 20 days of stopping or even tapering the steroids below 10 mg per. And this was his 3rd hospitalization in the last 12 months despite being on oral corticosteroids, LABA, LAMA, ICS, and he had also taken courses of ibuprofen. So he had a poor asthma control, ACT score was 16 despite the above medication. This was a CT scan, very classical bilateral central bronchiectasis. So we did a bronchoscopy and we found thick mucopurulent secretions which were aspirated and sent for cultures. His serum Ig was 1286. His comprehensive allergy panel was, the specific Ig was positive for Aspergillus, house dust mite, and a couple of other things. His fellow on in 3 occasions was found to be 63, 74, 58 parts per billion, which is significantly high and suggestive of pH2 inflammation, which of course you would expect in a patient with ABPA. The absolute eosinophil count was 197 per microliter and the cardiac workup was normal. So to summarize this case, this is a 60-year-old asthmatic ABPA. There's been no remission since the last 1 year on oral corticosteroids, LABA/LAMA, ICS and Montelukast, and he has taken 3 months of ibuprofen. He has low AQ, LQ and ACT scores, he has steroid dependence and he has recurrent exacerbations. Bowel culture showed growth of pseudomonas. He was treated with cefepime and topramycin nebulization. We discharged him on topramycin along with standard asthma treatment and 20 mg of prednisolone. On follow-up after 2 weeks, we started him on injection of omalizumab 375 mg every 2 weeks. By the 3rd dose, we could taper off his oral corticosteroids. In the current scenario, he has received 10th dose of omalizumab on 25th of June 2023. He is off steroids. He is on LABA ICS. There have been no exacerbations in the last 5 months. There's been a modest increase in the FEV1 to about 1.33 liters. The absolute eosinophil count is 138, and the FeNO has reduced significantly. It's now in the 30s, so still high. The second case is of a 48-year-old female who also happened to be the mother of our HR head, so quite a bit of pressure on us to treat her. She had been an asthmatic for the last 30 years on regular treatment. She had history of exacerbations that required hospitalization at least 2 times a year. And she was also on maintenance oral corticosteroids off and on. She also had a history of sinusitis with nasal polyps on lava-lama ICS Montelukast, and she was on adequate treatment for sinusitis. She presented to Dr. Nangia's OPD history of recurrent OCSUs, mostly methylprednisolone 16 to 32 mg dosages varying. As for the records, she would require OCS every second month or even before that. She had extensive wheezing, severe limitation of daily activities with an ACT score of 9, as low as 9. She had uncontrolled diabetes mellitus. She was also depressed. Prime concern was inability to lead a normal life. Her PFT also showed classical asthma features, reversibility of around 400 ml. The FeNO was extremely high, 75, 78, 84. Her absolute eosinophil count was more than 300, 345 per microliter. Serum IgE was 684, and we did a skin prick test which was positive for HDM, cockroach, alternaria, cat, dander and Cajunars. This was a CT thorax, by and large unremarkable, no significant bronchiectasis or any other anomaly. So to summarize this case, she was a middle-aged female with severe uncontrolled asthma, recurrent exacerbations, leading to depression, low ACT and AQ-LQ score, and uncontrolled diabetes mellitus. This was way back in 2020, when it was just the COVID era, and by then we did not have, and benzalazumab was just launched in India around that time. So this patient had eosinophilia and she also had a high IgE. But we started her on omalizumab 375 mg every 2 weeks. She was followed up for 8 doses, had 1 exacerbation during the course of 4 months. Was still requiring oral steroids for symptom control, which was more than 10 mg of preg. She continued to have dyspnea and her absolute eosinophil count, despite the oral steroids, was well above 300. So this is a classical case of omalizumab failure. And so we switched her over to injection benzalazumab, and after the first 2 doses, she reported a subjective improvement in dyspnea, less wheezing. After the 3rd dose, the absolute eosinophil count was 211. After the 5th dose, her PFT showed an improvement in the FEV1. The FeNO values were much lesser. And currently she has no exacerbations. She's also off benzalazumab for the last 2 months. Off oral corticosteroids. She's doing well on lava-lama ICS and the routine treatment for sinusitis. She's being followed up monthly in OPD, and her current AEC is 137. My 3rd case is of a 72 years male, and this case will also highlight how much havoc can oral corticosteroid use on a long term cause to a patient, absolutely otherwise healthy patient. So he had severe uncontrolled bronchial asthma requiring oral corticosteroids off and on for the last 10 years. And he had history of steroid-induced hyperglycemia, history of left sinus surgery 2 years back. This was the X-ray. Left-sided, right-sided pleural effusion. The CT scan showed features of right-sided empyema. So a person developing empyema. USG-guided chest tube insertion was done, and around 600 ml of frank pus was drained. His pus culture showed growth of pseudomonas. We started him on antibiotics as per the sensitivity. Because it was a loculated pleural effusion, which we saw on the ultrasound, we also did intrapleural fibrinolysis with streptokinase. We believe in giving 2.5 units of streptokinase over a gap of 24 hours. So after 2 doses, his X-rays started showing resolution. The repeat X-ray much clearer as compared to the first one. So to summarize, this was a chronic asthmatic on long-term steroids, has now developed empyema and steroid-induced hyperglycemia. We went through his old records. His last PFT was 2 months old, which showed an FEV1 of 1.3, reversibility of 256. FeNO was 89, 96, 99, again very high. His total IgE was 419, specific IgE was positive. Aspergillus specific IgG and IgE were negative. Absolute eosinophil count was 436 per microliter. He was discharged in a stable condition from the hospital. After we treated his empyema, we discharged him. And then on follow-up, we started him on injection benzalazumab, 30 mg subcutaneous. First 3 doses at a gap of 4 weeks, and then subsequently at a gap of 8 weeks. So this patient so far has received 3 doses. He is currently on LABA, LAMA and ICS only. Has not required any oral steroids in the last 3 months. Asthma is well controlled. His ACT score is 22. The absolute eosinophil count is 284, down to 284 from 436. So, Dr. Nangia had also summarized this different indications of different biologics. Basically, you can use benralizumab in chronic rhinosinusitis with nasal polyposis, eosinophilic esophagitis, EGPA, and one emerging indication for benralizumab is also in ABPA because it takes care of both the IgE and the eosinophilic component of the disease. So, and as far as the follow-up is concerned, before we decide whether a patient has responded or not responded to a biologic, we have to give them a trial of at least 4 months with the drug, and then only we see these response criteria in terms of the symptoms, the lung functions, exacerbations, the quality of life, improvements in comorbidities, and use of other concomitant treatments like oral corticosteroids, which should always be the last resort. So with this I conclude my short case series, and thank you very much for your patience.
I would just like to add on here. No, I'm just adding on these slides only. That Dr. Amina actually underplayed the gratitude that these patients have expressed to us after their recovery with the use of these biologic agents. The first patient was one who came on a wheelchair to our OPD the first time, was from Punjab, a Sardarji from Punjab, who had shown to practically so many doctors, including PGI Chandigarh, and then landed up with us with an acute exacerbation. When we worked him up, we found him to be having a pseudomonas infection. We first treated that because of the bronchiectasis. Then we treated him with the omalizumab therapy. And I mean, so once initially there was a dip in his clinical condition, again became wheezy, came back to us, readmitted, again managed, sent back home. Omalizumab continued. After 4 or 5 cycles, the wheeze disappeared completely. I mean, I have not seen the wheeze, even the cramps. The bronchiectasis cramps have also disappeared in his chest. The second patient, who was the mother of our HR head, once recovered with this, actually we all got an increment after that, so we are grateful to her, considering they were so happy with it. And third, of course, this patient that Dr. Amina presented with benralizumab again, where benralizumab was used after the empyema. So one, of course, this patient was so moribund that treating empyema or putting him through any surgery was not a possibility at all. So we did an ultrasound guided or a CD guided insertion of the pleural drain, followed by streptokinase instillation, which people at that time literally laughed at us that what are you doing, aajkal kaun karta hai STK. I said wait and watch and see the results. And the way the X-ray cleared up with the STK installation, I can't even tell you. And the guy's asthma who had been on steroids for such a long time improved so much that he went on to Google review. You know, usually people only post negative reviews on Google, but this is one of the few people who went on to Google review and posted a very good review for us and the team on the Google. His own son was working with Google and was full of gratitude for us. And this guy also now comes walking into the OPD, comes from somewhere in West Delhi to us. So, thank you God also that Amina is hanging in the ice.
सर ठीक होने के बाद में दारू पीना शुरू कर दिया होगी फिर होगी तो आपने प्रोसेस नहीं किया.
So this is only 3 series that 3 cases that Amina has presented.
ठीक रहते हैं मरते तब तभी ठीक नहीं होती एक्सपो चेकअप कर लिया.
I would request Dr. P. Sir, please sir. I would request Dr. P K Mangla sir to start the question answer session. It's 10:12. No, it's 10:07. We have the limit. Come, Shubham. Let's welcome Shubham. He's soon going to be head of gastroenterology unit head in Fortis Vasanpur. I'm sorry, we'll have a question on God.
Asthma की बात बोली है तो मुझे I have to basically ask you in your practice how common is atypical asthma and how commonly do you come across GRD presenting like asthma, like atypical no heartburns or no GI symptoms, but asthma. And patient is 40, 45 years old, female, related to bees, presenting with bees, responding to inhalers. How common is that? And do you think about atypical GIRD presenting in bronchial asthma? Thank you.
Absolutely. I think it is actually definitely more common than you actually think or anticipate. So in fact, most of our prescriptions to the first timers at least would be to start on a GERD drug, an anti-GERD drug along with a prokinetic agent, just out of this thing, that most likely they would be having an association of an element of GERD also along with it. So as I said, pure asthma is never there. It is always associated with a chronic rhinosinusitis, which is nearly about 70% of the cases, and a gastroesophageal reflux, which is there in 50 to 60% of the cases, even if they don't give you a proper history. Sometimes you just need to spend some extra time with these patients to elicit a proper history. Hiatus hernia is so many times detected, incidentally, which they never even knew when you get a CT scan done. So it's very, very common, more common than we actually think or anticipate.
We have Dr. P Mangla. He is son of Dr. P K Mangla sir. Let's welcome him.
Welcome.
He has a question.
Same history of the role of Benzaluzumab and Napolizumab. Just one question regarding the comparison between the Benzaluzumab and Napolizumab. Can you clarify for Benzaluzumab primarily and not for Napolizumab? In case.
So that's a very good question. So as I said, there are no head-to-head trials comparing one drug with the other. We don't even expect them to come in the near future. It is not easy. See, treatment is easy, but prevention is not so easy to gauge when you're using these drugs. And one of the most important factors that you consider in these patients is reduction in the acute exacerbations. So if you extrapolate the data from the various studies that have been conducted for Napoli and Benrali and collectively see, then the hospitalization rates were significantly lesser with Benrali as compared to Napoli. The acute exacerbation rates were significantly lower as compared to Napoli. Costs are more or less similar of both the drugs. Then hospitalization, acute exacerbation, and dosage is simplicity. You give them only once a month for 3 months, and then it becomes once in 2 months. So patients feel it more convenient and easy to come and take the drug.
Role of Benzaluzumab in ABPA, they will also have recently raised training levels. You also show one case regarding ABPA.
So that ABPA was treated with Omalizumab, but I'll ask Amina to elaborate more on this. There are more studies that are coming with the use of Benrali as well.
Basically, we have a very recent meta-analysis.
Mic is
Sorry, am I audible? So we have a very recent meta-analysis published in the Journal of Allergy and Immunology, which is primarily on Omalizumab. We've studied almost about 42 different case studies and RCTs. And in that meta-analysis also, it's seen modest increases in FEV1 along with reduction in exacerbation and reduction in the oral corticosteroid use, even cessation of OCS use. Also, now this is one study, also even if you look for more literature, now Benzaluzumab, particularly in patients who also have nasal polyposis or have frequent exacerbators, in them, for ABPA also Benzaluzumab has now become kind of the drug of choice, because although I would say that the literature is more on Omalizumab, but that may also be because Omalizumab has been there for a longer time, so there are lesser studies on Benrali, but whatever data we have, both are indicated, particularly for the eosinophilic phenotypes, which have a higher absolute. So my patient did not have an elevated AEC. If there is a patient with ABPA, also with sinusitis, also with an elevated AEC, then one will certainly go in for Benzaluzumab.
Ma'am, we had a CME on malignancy and we talked about immunotherapy. and we asked a question to him, how long do we do immunotherapy? He said lifelong. Once the patient is on immunotherapy, he is always on immunotherapy. And he quoted my if you have a hypertension, you give him treatment lifelong, nobody questions. If you have a diabetic, you give him anti-diabetics lifelong, no questions. If you have a bronchial asthma patient on monoclonal antibody, you give him a monoclonal antibody. Once on monoclonal antibody, he is supposed to be always on monoclonal antibody. Do you revert that man?
That may not be the case always. So that may not be the case always. So once on a monoclonal antibody doesn't mean that you have to be on the monoclonal antibody forever. Although, there is no end point that has yet been defined in the literature that you have to stop, say, when ranibizumab after X particular doses. But there are two things that have to be remembered. One, before labeling any biologic failure, labeling any biologic therapy as a failure, we have to wait out for at least 4 months to see how you won't get a magical kind of a response after 1 dose or 2 doses or even 3 doses. You have to wait for 4 months. And as far as the continuation of this therapy is concerned, so most people, 8 doses to 12 doses in most of the literature so far that we have, it's given, and it has also been noted that even after cessation of these biologic therapies, the patients still remain in remission, their asthma remains well controlled. But like I said, all of these modalities are relatively new, and we obviously need larger studies, more data. There is no endpoint defined so far, but we can stop after 8 to 12 doses, and then we can wait and watch. And if the patient has a recurrence, then we can always restart. But for most of our patients in whom we have stopped the biologics, so far luckily they have not come back to us with any increased complaints.
Sorry. One thing is there for sure that, to all my patients now who come to us, we categorically tell them right at the beginning that the way you manage your diabetes, hypertension, any cardiac illness, asthma, COPD are also chronic diseases for which you need to be on long-term treatment. Patient का सवाल इनमें ये होता है कि डॉक्टर साहब ये कभी जाएगा भी कि नहीं जाएगा asthma, and I tell them BP कभी जाता है, diabetes कभी जाती है, नहीं जाती है ना. You control them with medication only. You keep them under control with medication. Just the same way, asthma and COPD are also chronic diseases which require long-term treatment. The advantage is just the same way with hypertension. If the hypertension is coming under control, it's better you start reducing the dosages. Similarly for asthma and COPD, you start reducing the dosages and see if the patient is doing well or not. Any stage you feel patient is not doing well, then again you increase the dosages. But patient has to be on something of the other on a long-term basis.
Sir, second to what Madam said, that after about 6 to 8 weeks, maybe we can stop, or 6 to 8 cycles we can stop. In oncology, we have the tumor markers, so we can measure them and know whether the disease is coming back or not. What about bronchial asthma? Are there any surrogate markers? Are there any markers where we can monitor the patient over a period of time?
So absolute eosinophil count, PENO levels, frequent exacerbations. How often?
How often are we getting?
So you can check them every 3 to 6 months. There is no recommendation or guideline like this. How often to check them? But that's just like a routine.
Okay,
I guess it would go more by the symptomatology of the patient. See, you're not treating the markers here. You're treating the symptoms of the patient. If the patient is going into acute exacerbations or is not settling, so from controlled variety as I just showed you, basically you need to monitor the symptomatology of the patient. If the patient is requiring the rescuer inhaler more often, if the patient's night is disturbed, if the patient has more daytime symptoms, is not able to perform activities, the asthma quality, asthma control test, that is not proper, then, so there are all clinical markers that you would consider whether you need to now step up the therapy or step down the therapy.
Thank you, doctor. I would just like a comment. A secret from our hospital practice that more CT cleaners done by chest physicians than the ENT surgeons. We simply get the ready-made cases. Thank you.
Thank you for that. And I think most of you from my OPD only, you get the reaching you. I have a standard practice of getting a CD analysis done for all my patients.
Dr. Vivek sir, there is a fan of yours, the silent fan. Her name is Pallavi Purwa.
Ji, we just met Ji. Thank you so much.
She came all the way to meet you, sir.
That's so sweet of her. Really
She has done a DNB CTDS from National Institute of Tuberculosis and Respiratory Diseases.
One of the most prestigious units.
At present, she is working as a thoracic surgeon with one of the best thoracic surgeons of North India, Dr. S.S. Bal. She has a question, sir.
Ji, sure.
Hi sir, we kind of now are getting increased number of cases of lung cancer, and some of these, when they come from the peripheries, are uncontrolled asthmatics, and we really don't like to give perioperative steroids. So do you kind of recommend some other treatments for uncontrolled asthmatics who have like a very short span to get better before we can operate on them?
Sure, that's a very good question that you've asked me. So as I said in the beginning also, or in part of my talk, that we've gone away from the use of Duolin and Buticort as treatment for asthma. We rely more on long-acting beta agonists, long-acting muscarinic agents. For some reason, they're still not as popular as we use it in our unit now. So we made it a standard policy that our patients would be on a Symbicort inhaler or a similar nebulizing solution, along with a glycopyrronium nebulization twice a day, along with, if the patient is on an OPD basis, you could consider adding azithromycin, or you would consider adding a short-acting beta agonist along with it. So the asthma treatment has also evolved majorly over the years. Oral corticosteroids usage has come down significantly now. And what we believe in is that also that there's no need to be tapering the dosages. What you can also do is give them high dosages of some steroids for 2 days, 5 days, 7 days pre-operatively, and then just stop it abruptly, get them operated, and they should be fine in the post-op.
Thank you so much.
Sir,
I think if you are going to operate upon a patient who is an uncontrolled asthma, I think it is worthwhile giving a short course of steroids. Otherwise, they become very high risk for anesthesia. They can go into status asthmaticus, and it is worthwhile giving them for 3 days, operate the patient, and I think it doesn't do anything.
Sir, Dr. H.P. Singh, another question.
Thank you, sir. First of all, sir, great applause to the speakers from our audience. Great applause. Very great. Sir, my question is, as per, sir, even in first sentence, when they written it is an inflammatory disease. In first sentence. So the inflammatory is for the management by the corticosteroid or some antibiotic also indicated. Number one, inflammatory means some infection is there, but you have never told about the antibiotics. It is only steroid or Bengal Jimam or whatever. Question number one. Question two. The disease is asthma is a child to the death of the patient. So variations are there. Whole life patient have to take the medicines. There is no cure at all in the life. He has to struggle forever in the life with the whatever it may be. So my question is, pertinent question is there any remedy, any research about this disease can get rid from the asthma?
Cure.
This is my question.
Good question.
All the questions are very good, sir. So basically, when you talk of infection, whether it's bacterial, viral, infections also result in an inflammatory cascade, which then results in sepsis and the complications. So there is a different pathway altogether. This is inflammation. Of course, viral infections, exposure to dust, exposure to pollens, exposure to animal danders, they could all trigger off an inflammatory cascade, which could be IgE mediated or eosinophil mediated. So there's a different pathway of inflammation altogether. So here, the antibiotics do not have a role. Inhaled corticosteroids are considered to be the backbone of treatment of asthma patients. Oral corticosteroids come at a much later stage. In fact, you avoid them as much as possible. So ICS is what would be the backbone of asthma patients. That is one part of your question. Second question was cure. So as I said, like diabetes, hypertension. The only diseases that can be cured are infections, which go completely. Rest all diseases, the chronic diseases, the lifestyle diseases, they're all kept under control with regular medication. You're talking about asthma starting from childhood. When if it is allergy driven, you treat their allergies, it may come under control. You avoid exposure to the allergen. So again, proper holistic workup is what is necessary. A child who is developing asthma usually grows out of their asthma by their teens. So if it is still occurring at the age of 20, 30 years of age, then you need to approach the patient holistically, check for the triggers. If the patient can avoid those triggers, very good. You know, there's so many patients who have a problem as soon as they land in Delhi. You know, the patients who are coming abroad, patients who are coming from Goa. The moment they land in Delhi, they start wheezing because of the pollution. So, will you call that asthma? Or is it just because of the environmental pollution that is happening? So, if it is because of pollution, you change the source, change the city of living. Obviously, this asthma will come under control. So, you have to do a holistic workup and figure out whether there are some modifiable risk factors that you can modify or not.
So those were really very important and interesting talks you gave, and many of the lessons from the previous talk got revised. What I want to know is dupilumab and TSLP biologicals, they are not available in India as yet. But when available, where would you position them? When would you like to use?
Very good question. So anti-TSLP, that is tislelizumab, is basically a drug for which you don't need any criteria. You know, any patient who's not coming under control with your regular maintenance therapy, you don't need to check eosinophil levels, you don't need to check IgE levels, just start the patient on that therapy and it will supposedly come under control. Dupilumab is basically again an eosinophilic variety with patients on oral corticosteroids and you're not able to taper the doses, then you would use dupilumab.
In allergic rhinitis, we are often using Benocid food, and it has to be given for about 3 weeks or so. Is there any role in asthma also?
So, very good question, sir. Again, Benocid 4 is mainly an anti-helminth drug, which you would give to a patient who has a mildly elevated eosinophil level, where you're suspecting a helminth infection. So, in all these patients, there was also a big debate that whether the eosinophil levels in Indian patients is the same as the eosinophil levels in the Western patients. Because in India, these worm infestations are so common, hookworm, ascariasis, all of that. So what we do as a practice is, that when you find an elevated eosinophil level, we first deworm the patient and then check the eosinophil levels again after a few days and see. As I said, just one value of AEC is not sufficient. You check it 3 times at least, at different times in life, before an exacerbation, after an exacerbation, before the use of steroids, after the use of steroids, and then see how.
Not after 2 weeks of the is there any period or only after?
So there is no specified period as such, because there is no specified time frame that you have to start the biologic also tomorrow only. You could do that 1 month later also.
Sir, do you have any experience of a grass called Parthenium grass that exaggerates patients? It's called the carrot grass or the Parthenium.
Very often in the skin prick test that we do find people allergic to it. It's a part of our SPD.
Sir, I'm sorry, but we have only 5 minutes for your DM Viva, and we have got the GPS.
So I am not a DM candidate, I should be exempted from this.
He's just joking. So I have some very simple questions to you.
So obviously answers only you know.
Go ahead. Sir, let me begin. So despite the development of groundbreaking...
No sir, but first I need to know what do I get after I answer your question.
Chocolate incentive.
Clapping.
Anything you desire, sir? Okay, let me proceed. So Dr. Nangia, after that wonderful talk and some wonderful questions from our colleagues, some simple questions from me. So despite the development of groundbreaking and revolutionized new therapies for severe asthma over the last 2 decades now, certain group of patients will not respond, and those patients which you cannot categorize in any phenotype. So challenges still remain. What do you say, sir?
Absolutely, sir. I agree with you. So there is a 10-20% of the subset of patients who would not classify for any of these biologic agents.
Right.
That is where you have to have a relook at the patient. So my approach always to a patient is that keep having a relook. Even in our ILD patients, when an ILD patient comes to you, you get an autoimmune profile done, it is negative the first time, you check it again after a year, the CT scan has changed so many times, the patient who was labeled as an NSIP initially, has after 1 year turns into a UIP pattern, you get the autoimmune profile done, the autoimmune profile suddenly becomes positive. So these kind of changes are only human in nature. So these 20% of the patients who do not fall into any of these categories, you need to have a relook whether your diagnosis of asthma was correct or not, whether the patient is still complying with the therapy or not, is the inhaler technique correct or not, whether the patient requires a bronchoscopy. So okay, now I'll give you an example. We had this young girl, 2 such patients, young girl, young women, both of them. Constant wheezing, you get everything done, everything was normal. They had been treated across the city by senior pulmonologists of the city. All we did was admitted both these 2 patients at 2 different times of course. Did their bronchoscopy, and what did we find? Endobronchial tuberculosis. So the diagnosis of asthma was totally incorrect. Vocal cord dysfunction is very common in these patients, which you could miss out. Stridor is very common. Endobronchial tumors. We've had patients with endobronchial tumors being treated as asthma. And out of these 2 young ladies, one of them is a medical student herself from Subsidiary Hospital. Another one turned out to be having a leiomyoma inside. So, those are the kind of diagnoses that you come across.
Important to diagnose, and let me proceed further. So, just a talk on airway remodeling, which has come a big way now. Ever since the biologicals have been introduced, we know ICS have a role to play in reversing the adverse remodeling, airway remodeling. But what about the biologicals? I believe they have a big role to play. And they say you start, when there is severe persistent asthma, why can't we start this little earlier to reverse the remodeling? Tell us about that.
Again, it's a very, very good question. So basically, airway remodeling is more of a fibrotic process that is going on inside, where the muscles are becoming now thick, stiff, and irreversible.
ASL.
Sorry?
ASL.
The ASL, yes. So they are all becoming thick and irreversible. Of course, it is a very good idea to start it early, but then you have to have a criteria for using it. If you start using it rampantly, then probably every patient who's walking in, you start using the biologics only in the
Why not, sir?
1, because of the cost. 2, because of the long-term side effects we still don't know. After all, they have only been in existence for the last 5 or 10 years and not more than that.
2 decades now. 20 years ever since you died.
Only Omalizumab and Rally and all are more recent. So that is one. Second is that if somebody can be managed with just simple inhalers. So my belief is that if you start the inhaler therapy early in life and are able to control the symptoms early in life, then probably airway remodeling will also not happen.
Absolutely. My last question, sir, regarding combining 2 humans, combining 2 mats. One is man and the other double mat. Can we combine these? They have synergistic effects. The patients who cannot be controlled on one mat, you could always add another. This is a recent research article which I read. Tell us about that.
So again, that's a very relevant and good question and very interesting also. But we just have
This has been done. Dr. Nangia,
Yeah. That is more of a research that has been done here.
Yeah, but patients who do not respond to one mat, you could always add another mat simultaneously, concomitantly. Thank you, ma'am.
Sir, having had a very long session, very nice questions and very nice presentation, I firstly want to commend my dear friend Dr. Chauhan for his efforts taken for the invite. He is of late laboring so much. जैसे आपका उन्होंने synopsis बना के भेजा है और one of our friend is giving synopsis after the talk. That makes it wonderful. So, Before I ask you a question, sir, I just want to add to how long treatment should be done. Many patients ask me, diabetes का treatment कितना चलेगा? If it is not genetic, if it is lifestyle related, as long as he can modify his lifestyle, he can change. It is very much possible. So if we know the cause of asthma and if we can modify, so things are easy. We can tell that as long as you change your lifestyle or say city as you said, you can change. So my first question is about the patients of severe asthma. So is it a routine to get IgE, eosinophils, FeNO? Does blood group also matter? Because this is also one of the phenotypes or endotype, what you can say. Does it matter to the treatment? Blood group. Have been at times given different diets also, if you remember.
Yeah, but correlation of blood group and asthma, I haven't really studied about it. I mean, if you have, then maybe there is some research article that you must have come across. But I haven't read any correlation between blood group and asthma so far.
Some patients have food allergies also. Does the eosinophil count due to food allergy matter into that?
Definitely it does. But I would only want to say here, Dr. Shubham is also here and I think he'll bail me out on this, that when you have a food allergy, then respiratory symptoms are not so common. Food allergy would manifest more with gastric symptoms. Enteritis, nausea, vomiting, maybe skin rashes, but not with respiratory symptoms. Respiratory symptoms do well with atopic, that is a skin allergy.
My point is you both are combined. Patient has food allergy and asthma. So we will be labeling it wrongly to the asthma, eosinophilic asthma, or will it be...
so treatment would still be the same.
Right.
Even in eosinophilic esophagitis, you would use these MABs.
So bronchial thermoplasty at times is used. Is laser also one of the modality are you using? Or it's yet to be used?
So bronchial thermoplasty was another very revolutionary technique that you would do under bronchoscopy. In a patient, it was one of those 20% of the patients that Dr. Tulsi mentioned who were refractory to, not candidates for any of the biologics or refractory to biologics, we would do bronchial thermoplasty. But over the years, initially it came with a very big bang. We also did it for 2 of our patients. One was an international patient and one was a domestic patient. We found very good results. Both the patients who were constantly on steroids and not improving. In fact, one lady had already received Vivek abroad. She had come from South Africa and then come to us, and then we done a bronchial thermoplasty in that patient. But and she went back very happy. She gave a very good testimonial also, which still plays in the hospital every now and then. I see that. But now recent data has shown that the benefits of bronchial thermoplasty are not as much as any of these MAB therapies is concerned. So
I'm known for my half question. My last half question is, in your case of the case 2, the pleural infection. So you gave that, you gave urokinase or streptokinase. Can urokinase be used? And if are you using any antibiotics also intrathecally?
So intraplurally, I remember using a colistin in one of our patients who had come to us with a Burhave syndrome leading to empyema, and we were not making a headway with her. She was in a appointment condition, could not be operated. So in just one patient we have used that.
You can answer the rest of the question, Amina. Yes, and P K Mangla sir to give his words of wisdom at the end of this wonderful talk and question answer session.
Thank you, Dr. Nangia, Dr. Amina. I also had experience of using benralizumab in one of our doctor colleagues, who would very frequently call me, "Yaar, ye fir ho gaya. Kya karna hai? Give me Metrol." Then again 3 days tapering, again get UTI and things like that. And I suggested him, it's been 5 months. he hasn't had any attack. And he told me, he called me 2 days back, "Can I report देना छोड़ दूँ क्या?" बिल्कुल ठीक. So it is effective. It is very effective. And regarding this severe asthma, one should always see eye drops, drugs, NSAIDs, and reviewing diagnosis. I think something is missing somewhere. You see, it could be his room, it could be carpets, it could be beds. All these going into details really help. Thank you, Dr. Vivek. Thank you, Dr. Anil.
We had one clarification left. I would request Dr. R.K. Sharma and Dr. Sarla Sharma ma'am to come here.